Just want to do a quick sound check again. Everyone can hear me good?
Yes.
Okay, perfect. All right. So let us get started for today. Good morning, everybody. My name is Chloe. My preferred pronouns are she, her, and I am the communication coordinator for the Sickle Cell Awareness Group of Ontario, and I will be moderating today's session titled Learning for Life Session, Novel Therapies in Sickle Cell Disease, What Patients and Families Should Know. If you or members of your network would like to refer to the information in the session today, a recording of today's session will be posted at our website for viewing at your convenience. Now, one of our missions at the Sickle Cell Awareness Group of Ontario is to serve as a conduit for members of our community to access evidence-based, up-to-date information that we have prepared for you for this morning. Today's session is incredibly important because uh, the treatment landscape for sickle cell disease is rapidly changing and faster than any point in history, and every person in this community deserves to learn what this means for them. As well as that, what we hope to do is to guide you through a couple different topics today, some of the new emerging therapies in sickle cell disease, how we can ensure that we have equitable access to these therapies, and also understanding what they might mean in the context of the pediatric population. In this session, we will be hearing from two speakers who I will introduce shortly. Our agenda will start with a couple additional housekeeping rules as well as a land acknowledgement, and this will be followed by the presentations from our guest speakers, and at the very end, we'll have a question and answer session. Now, for our logistics, as I mentioned, the session will be recorded. And if you have any questions, thoughts, or concerns, we kindly ask that you save them into the latter portion of our session during the Q&A, where guests will be able to answer the questions individually. Alternatively, you can put the questions in the chat with who you might want to address the question to if there is someone specific. So you can potentially say question to all, which we will know to indicate that the question is for all of the panelists. We also kindly ask that you respect that learning be done in this space by abiding by the following housekeeping rules. Firstly, microphones should be disabled for the duration of the webinar. If you would like to ask a question, please do so in the chat or QA function. And we will try our best to answer all questions during today's session. Closed captioning is provided and can be selected using some of the additional options available on Zoom. Please also use respectful language in the chat, no profanity or inappropriate images or posts, please. Please do not post any material unrelated to today's discussion topic, and also to keep discussions and comments on the topic as much as possible. We also want to mention that the SCAGO reserves the right to pause the session or to seek removal of participants who may not be abiding to these rules. We thank you for your understanding and agreement to positive participation. As a further disclaimer, we want to remind individuals on the call that the information shared today does not constitute medical advice and it is shared with you for information purposes only. No materials shared with you today are intended to be a substitute for professional medical advice, diagnosis, or treatment, and always seek the advice of your physician or other qualified healthcare provider with any questions that you may have regarding medical condition or treatment before undertaking a new health regime. Please do not disregard professional medical advice or delay seeking care just because of something said in this webinar. With that, I would like to go towards our land acknowledgement. We are very grateful for the opportunity to gather, though virtually, on this land, and we thank the generations of Indigenous people who have taken care of this land long before other nations groups came. In particular, we recognize the traditional territories of the Ojibwe and Anishinaabe and the Mississaugas of the New Credit, whose territory is covered by the Upper Canada Treaties. We also recognize the contributions of the Métis, Inuit, First Nations, and other Indigenous peoples who have made in shaping and strengthening the province and this country as a whole. We also need to continuously educate ourselves about the colonial history of this country and understand how the wrongdoing of the past still impacts the present and the future. I encourage everyone at the session to actively seek information and take action. With that in mind, I would like to introduce some of our speakers for today. I will introduce both of them and then I will bring up the first speaker. So to cover the topic of pediatric conditions for novel therapies, I have Dr. Jody Adame. She is a staff pediatric hematologist oncologist at McMaster Children's Hospital in Hamilton. She holds a Bachelor of Medical Sciences from Western University and a Master of Science in Physiology from the University of Toronto. After completing medical training at the Royal College of Surgeons in Ireland, she pursued general pediatrics at Cincinnati Children's Hospital. Dr. Odami focuses on hemoglobinopathies, particularly sickle cell disease, and is dedicated to improving care transitions for adults, adolescents, and young adults facing systemic challenges. Currently working towards a master's in health systems leadership and innovation, she aims to advocate for better sickle cell disease policies and support. Following Dr. Odami's presentation, we'll have a presentation from Ms. Jane Jackson titled Ensuring Individuals with Sickle Cell Disease Receive Equitable Care. Based in Ottawa, Janet Jackson is a healthcare advocate, professional, and dedicated mother to an 8-year-old daughter living with sickle cell disease. Her unique perspective is shaped by a diverse professional background. She holds a degree in sociology, a paralegal diploma, and frontline experience as a personal support worker. Driven by her personal lived experience as a parent, she champions systemic change to ensure individuals with sickle cell disease receive equitable care. As a community leader with the Ottawa Black Mental Health Coalition, she is deeply passionate about addressing intersectional mental health impacts of navigating a chronic disease on both patients and their families. Her extensive advocacy includes serving on the patient and family advisory councils and leading grassroots initiatives to integrate critical sickle cell resources into local public health programs. So we have many illustrious and esteemed speakers with us today, and I'll first bring up Dr. Odami.
Thank you so much, Chloe. I'm going to take a moment to share my slides, so please let me know once you can see them.
Of course. Yes, they are in presenter.
Okay, thank you. Good morning, everyone. Thanks for everyone who took the time in the weekend to join. I know everyone's very busy, so we really appreciate it. I wanted to take some time to talk about some of the novel therapies in sickle cell disease. We are very fortunate to live in a time where drugs can actually come up very quickly. And sometimes they move forward and get approved, and sometimes they don't make it past the finish line. So I try to give the most up-to-date information as of April 2026. So hopefully you can hear about what's out there. So just in general, therapies for sickle cell disease can be put into two categories or two groups. So we can talk about curative therapies. So these are therapies who have a goal to cure the disease. And then there are also some disease-modifying therapies, which are any therapies that don't cure the disease, but aim to reduce the complications of sickle cell disease and improve the quality of life. So throughout this talk, I'm going to talk about most of them. For the sake of time, I won't talk about hydroxyurea because it's not very novel, but I will take time to talk about the rest of them. So starting with curative therapies, I'm sure a lot of people have heard about bone marrow transplant. So I wanted to take some time to explain what it is. So our bone marrow, which is the material or tissue inside our bones, contains stem cells, which are essentially the factory that are programmed to make our blood cells. So what we want to do in bone marrow transplant is to find a donor who doesn't have sickle cell disease and take their stem cells from their bone marrow and introduce it to the marrow of someone who has sickle cell disease so that the healthy blood cells can now make healthy red blood cells in the patient. But in order to do this, the donor needs to be a genetic match. So when you look over on the right here, you can see they take the donor cells here, they collect the stem cells and preserve them. And then what needs to happen in the patient is you need to suppress them. And they use chemotherapy or radiation in varying doses depending on the type of protocol that they use. And that's because you want to suppress the immune system and to create room in the bone marrow for the donor cells. So once you've created that room, you can bring the donor cells into the patient. And then if it's successful, then the patient actually starts to make healthy red blood cells rather than sickle cells. I wanted to show this figure because I think sometimes it can be confusing when we say someone is a genetic match for bone marrow transplant. And you might have some idea of how having the same blood type as someone is. So it's kind of similar, but it looks at a different protein or antigen on the blood cells. So let's take, for example, a mother who has an orange diamond and a blue circle as their code for their HLA typing, which is what we use to match for bone marrow transplants. And father has a red square and a green triangle. If you see the different scenarios of the children they bear and what the different combinations can be, you can see how even if people have two parents, two siblings might not be a match to each other. So let's say, for example, someone who has sickle cell disease is a blue circle and a red square. Ideally, you want another sibling that's also a blue circle and a red square. So this is a very simplified diagram to show that all these people can be siblings with each other, but actually have different HLA profiles and may not necessarily be a match to each other, even though they're related. So as I talked about before, you need to prepare the patient to be able to receive the donor cells. So there are two types of preparation, or what we call conditioning methods. And this is important to understand because it determines the different types of bone marrow transplant one can receive. So there's one called myeloablative, and this is when you use higher doses of chemotherapy and radiation to almost completely wipe out the marrow to make room for the donor cells. There's also non-myeloablative, so you don't completely wipe out the marrow of the recipient. You use lower doses of chemotherapy and radiation just to make just enough room for the donor cells to come in. Right now, most Ontario centers, which is mainly Ottawa and Toronto, that offer a bone marrow transplant for children and adults, use a non-myeloablative method. So, what are the side effects? So, whether you use myeloablative or non-myeloablative, after the transplant for a period of time, all your blood cell counts are low. And that's because it takes time for the new donor cells to actually start working and make healthy blood cells. So, when your blood counts are low, you're more prone to bleeding. You have a higher risk of infection because you're not making white blood cells which fight infection. And because you're anemic, you have fatigue and weakness. So this is why shortly after you actually get the transplant, for several weeks, you have to stay in hospital so that they can support you through this phase. Now, with any transplant, there is also a risk of what we call graft rejection, which is just that the donor cells don't take, and then the sickle cell marrow grows back. When you use a non-myeloablative protocol, there is a slightly higher chance of graft rejection, and this is probably due to the fact that the old marrow wasn't completely wiped out. But non-myeloablative bone marrow transplant is still favored for a couple of reasons, and that's because you want to minimize the long-term effects of bone marrow transplant, which can happen because you're using very high doses of chemotherapy and radiation. So one of the things transplant physicians always watch out for is graft versus host disease. And this is a situation when the donor cells, once they come into the patient's body, see that cells as invaders and start to attack with their immune system. And it can affect all the organs and particularly cause severe rashes and tends to affect the gut and liver as well. So that risk is higher if you use a myeloablative protocol, but you can reduce that risk by using a non-myeloablative protocol. And with high doses of chemotherapy, you can cause infertility, and that's what you are trying to reduce the risk of in non-myeloablative transplant. So the risk isn't zero with it, but it's very low compared to myeloablative transplant. And no matter what type you do, they can offer fertility preservation for children who are older, especially in pubertal age. But there are some other methods coming through the pipeline to offer ovarian tissue preservation and other methods for kids who are younger than that. So what if there's no sibling match? Because unfortunately, only about 20% of people living with sickle cell disease will have a full genetic sibling match. There are some people through studies or in other centers conducting transplant with what is called a half match. So, meaning only 50% of your genetic code has to be the same. So, most first degree relatives will be a half match. You'll be a half match to a parent or potentially other siblings that might not be a full match. The results tend to be more promising in adults, but they're less successful in children. And that's because children have a more aggressive immune system. So, they're just more likely to see that other half that you're not a match to as foreign and it will cause issues. But there are some centers here and there who have done some successful haplo transplant. And I think as time progresses, we will get better at doing this and causing less side effects. But for now, majority of centers offer full sibling match transplant. So that's the main mode that's offered for children. Okay. So now I wanted to talk about gene therapy, which is one of the newer ways to try and cure sickle cell disease. So it's a little bit different. In this situation, your own stem cells are extracted from you, and then they're sent to be a lab to be genetically modified in a way that you'll tell the genes to stop making sickle cells and make healthier cells. And then they're infused back into the patient. So one of the main ones that have been recently approved by Health Canada is Casgevy. And you can see in this picture here, what it does is it uses a CRISPR or Cas9 technology to turn off this gene here, the BCL11A gene. What this BCL11A gene does when we're older is it usually blocks the signal that makes hemoglobin F, which is a fetal hemoglobin, which is a healthy hemoglobin that makes good, healthy red blood cells. So what we can do by genetically modifying is we can snip a little bit of it that blocks this so that this is turned on again. The good thing about this is when you modify things at the gene level, unlike hydroxyurea, which when you take by mouth increases hemoglobin F in some red blood cells, this aims to increase your ability to make hemoglobin F in virtually all your red blood cells because you're changing at the genetic level. And once you're making more hemoglobin F cells, you make less sickle cells, and you essentially cured the disease. So, what are the side effects of Casgevy? A lot of them are similar to bone marrow transplant. The main thing is you do need myeloablative chemotherapy, so a stronger chemotherapy dose to make room in the bone marrow for your genetic modified stem cells. So the risk of permanent infertility and graft versus host disease is higher. But like I mentioned before, there are fertility preservation options, and you're monitored in hospital for several weeks and afterwards to make sure you minimize the side effects. Because of that, as of right now, if you do have a matched sibling donor, transplant is often preferred over gene therapy. Now, there is another gene therapy that's not approved by Health Canada yet, and that's Lyfgenia. And it alters the genes in a different way. Rather than cutting something out to turn something on, it actually adds a new gene through a harmless virus. So it's a virus that won't harm you or make you sick, but it's used to as a transporter or a vector to insert a functioning copy of the beta globin gene, which you need to make healthy red blood cells. So that one has been approved in USA in 2023, but not yet by Health Canada. And that's because of the potential increased risk of blood cancers. So I think Health Canada is waiting for a little bit more information to decide about Lyfgenia. For Casgevy, it was approved in by Health Canada about a little over a year ago now. But it's very expensive. So that's something to think about as well. And there hasn't really been any decisions made about what the cost will be in Canada and how we're going to fund it, how the government's going to fund it, and how we decide who gets it first and who gets priority. So while it is approved, no one actively is getting it yet off trial. So with some time, our hope is within the year it will be a clear understanding of how it's funded, who's going to get it, and we can start offering it to people who don't have a matched sibling donor. In terms of future directions, there are some other ways they're looking at possibly giving gene therapy, and this is an in vivo method. So rather than taking the stem cells out, you sort of offer it directly into the patient. And what would be nice about that is you wouldn't need myeloablative therapy, And so you wouldn't have the chemotherapy and all the side effects that come with it. But also, what would be nice about it is it would be feasible in low resource settings. So you wouldn't have to go to a fancy lab to alter the genes. It could be offered in communities or lower middle income countries. So that's something that scientists are working on. And within our lifetime, for sure, we will start to see, even within the next 5 to 10 years, we will start to see some of these come through. So I just wanted to show this diagram to kind of show the difference between transplant and gene therapy. So let's say a patient is referred for a curative therapy. If you're going through transplant, you need to assess for eligibility and search for a donor. Once you find a donor, you go through a transplant, you make sure they have a match. Then the donor stem cells are collected via blood or bone marrow and then given to the patient and infuse. And then usually at least a month, maybe sometimes up to 6 to 8 weeks, you're in hospital for management of some of the side effects. And then once you have evidence that the new donor cells have started to take and you're making healthy blood cells, you can go home and then you're followed up in the clinic to look for signs of any late side effects. With gene therapy, the patient comes in, they collect their stem cells, they're shipped to a big facility where the genes are altered and modified. Then they return to you, and then by this step, it's the same. They're infused. We watch you for short-term side effects, wait for the cells to take, and then you go home. So now I wanted to move and talk about some disease-modifying therapies. So there have been quite a few that have come through the pipeline over the last even 10 to 15 years or so, but I'll talk about a few of them. So one of the ones you might have heard of is L-glutamine, or the drug name Endari. And this is an amino acid, which is kind of the building block of proteins. What this drug does is reduces oxidative stress within the cell, which can make the sickle cells more sticky, um, rigid, and because of that, they can stick to the vessel wall and cause blockage, and that's what causes vaso-occlusive or pain episodes. So this is a daily medication taken by mouth. It's a powder that you can pour into some water or some liquid, and it dissolves, and you can drink it. So there was a phase 3 clinical trial that showed that people in the L-glutamine group had fewer pain crises and hospitalizations compared to those who took a placebo or weren't taking the medication. But it is worth noting that 2/3 of the people in the L-glutamine group were also on hydroxyurea. So it's hard to say how much of that was because of that versus the other drug. So this has been approved by FDA as of 2017, and there are some people in the States who are using it, and it's approved for use even at a young age, starting at 5 and up or so. But it's not yet approved by Health Canada. There are some people who have thought about using it off label, but that is with caution because the L-glutamine that's available in your pharmacy as sort of a vitamin or a supplement might not be the same formulation as this drug. So just to proceed with caution with that, that's usually not recommended. The next drug I wanted to talk about is crizanlizumab, and this is a monoclonal antibody that binds to something called P-selectin, which essentially is an adhesion molecule. It usually helps blood cells stick or other things stick. So when you bind to this, you prevent things from sticking together. And when that happens, you don't have sickle red blood cells sticking together. You don't have inflammation and white blood cells sticking together. So in theory, reduces the risk of pain episodes. So there was a phase 2 clinical trial where patients on crizanlizumab had significantly lower rates of pain crises compared to those not taking the drug. And because of that initial study, the FDA in USA rushed to approve this drug in November 2019. And then shortly after EMA, which is kind of the Health Canada or FDA of Europe, approved it in October 2020. But after that, there was a larger phase 3 trial that showed there was actually no difference in the rate of pain crises between those taking the drug and those not. So based on that data, Europe actually decided to pull back and no longer approve it as of May 2023, and Health Canada has not approved it as of yet. So this is something that I think is not as successful and has since been pulled, but it's something that you should be aware of, and perhaps in the future they will improve on this drug and it will come back. The other one that you might have heard of, which is sort of a lesson on the importance of safety, is Voxelotor. And this came out a couple years ago. And what this drug does is prevents red blood cells from becoming deoxygenated. And that's what causes them to form that sickle cell shape. So if you can prevent that, then you don't get the sickle cell shape and you don't get pain crises or other complications from sickle cell disease. So back in 2019, there was a phase 3 clinical trial, and it was noted that it significantly increased hemoglobin levels and reduced the rate of red cell breakdown. So because of that, there was an accelerated approval, but then it was abruptly pulled by Pfizer back in 2024 because there was new data showing that there was actually higher rates of pain crises and increased risk of death. So this drug is no longer available. But with every drug that isn't as successful, there are other drugs that come out that are more promising. So this is one of the newest drugs that are being studied, and it's called etoposide. And this is a pyruvate kinase activator. And what that does by activating that particular enzyme, pyruvate kinase, is it maintains the structure of the red blood cells and allows them to survive for longer. So as of just last month, the Hibiscus phase 3 trial released an update that showed that their data shows that there's a 27% reduction in annual pain crises and almost a 50% reduction or 50% increase in hemoglobin compared to those who don't take the drug. So this drug sounds very promising, and Novo Nordisk, the drug company making this drug, plans to file for FDA approval this year. So we'll be interested to see after the FDA reviews the data if they approve it. And usually when things are approved, if they don't have any concerns, Health Canada follows shortly after. Okay, so to conclude, as you can tell, the landscape of sickle cell disease treatment is changing rapidly. Most of the drugs I introduced or the curative therapies I introduced, some of them came out within the last 10 years. And we live in a situation where curative therapies are now available, and more curative therapies will become available in the future. The challenge is ensuring safety, both with short and long-term effects. And as you can imagine, sometimes it takes time to witness the long-term side effects, right? So you learn as you go. And not only that, but a lot of these new therapies are very expensive. So once they become approved, there's still that extra step of figuring out whether governments are going to fund it. If so, how we're actually going to realistically introduce it into our Canadian healthcare systems and offer it in an equitable manner that's fair and reasonable for the patients. But outside of the curative therapies, as of right now, hydroxyurea still remains the best and most affordable and most accessible modifying therapy to Canadians living with sickle cell disease. So I know that was a lot of information. I'm happy to answer any questions or provide clarity because I know this is can be complicated sometimes. So thank you so much for your time.
Thank you very much, Dr. Adame, for a very thorough and exciting presentation. I think we have a lot to look forward to in terms of this novel therapy landscape. Next, I'd like to bring up Ms. Jane Jackton to share some words about the ensuring equitable access to these kinds of treatments.
Well, thank you, Chloe, and thank you so much, Dr. Adame. It's an honor to be here. And when you joined the meeting, the webinar, and I'm like, yes, Black medical female doctor, hematologist, oncologist, yes. So just thank you, thank you, thank you. And I'm excited. I'm excited to have you on board for our families and all the work that you're doing and will continue to do. So just a little gratitude there. I want to thank Skago for this opportunity. And I do want to say that when my daughter was diagnosed at birth, um, my my first experience with sickle cell disease, I had, I knew I had friends, family members, that were living with this disease. But when I had my daughter, um, it was like, whoa, okay. What does this mean? And through Skago, they had like a seminar on hydroxyurea, and that was sort of my first little window of involvement with Skago. And so I truly just want to thank Skago for even for all the work and leadership that they're doing with regards to spreading awareness and advocacy for our loved ones. So I'm here to speak on equitable access to care, and I don't have any slides. I do have some talking points, so I'm sorry. I tend to try to speak from my heart. And I'm sorry that I'm dripping the allergies, Chloe. Excuse me. So, while, clinical advancements are exciting, therapies only work if patients can access them, understand them, and most importantly, feel safe receiving them. As I reflect on the topic of what families need to know about these emerging therapies, I'm reminded of the powerful discussions that just wrapped up. I just attended the National Black Mental Health Conference organized through Ottawa U. And the energy there was clear. We are entering into a new era of health advocacy. And it requires us to completely dismantle traditional top-down approaches to research and data collection. So we are here to look at novel therapies through the lens of community care, advocacy, and patient reality. Um, so the first thing is literacy and understanding. How do families cut through the medical jargon of novel therapies to make informed choices? Um, it's important that we ask the right questions. Sometimes we don't know what questions to ask, because it's based off of information that we're getting. Um, uh, Parents like such myself, it sometimes it takes a while to process information. Um, and this is without no medical background, no, scientific background. So it can be intimidating. And um, and what happens when the information is intimidating, uh, we don't know what to ask. And so we might not ask. Um, and so, but it is important that we do ask. And and when we don't know, we don't know. And so I think where healthcare professionals um come in is just ensuring that, like what you did today, Dr. Odame, yes, there's a lot of medical jargon. It is a lot of information, but you broke it down, and you've tried to simplify it as much as you can, and so thank you for that. Because I was like, what is BL11? But you explained what that was. So thank you for that. And and that's what this is about, the honesty, the accountability, and transparency over the solutions. The second part would be the systemic hurdle. So I know that for healthcare professionals, especially when you're working within the system, it's it can be challenging to sort of question the system. Um, because for several reasons, you don't want to, hey, it's your livelihood, don't want to stir the boat. But it is important that, we parents, families, caregivers, patients, we work together, we collaborate, and we support, we're allies, we're allies. Um, there's regional disparities in care. We know this. There's socioeconomic factors. and systemic challenges of navigating a complex healthcare system. It is so vital. It is so vital that we operate from a place of grace. Um, so when we're asking questions, when we are, it, it- you know, it there's it's not we're not questioning this, we're not questioning the medical professional. We're not questioning, you know, your work. It's beyond that. I think people have been traumatized. And when you spoke about the medication that is no longer um on the market, it made me think, oh, okay, what happened there? Who are these individuals, families that were affected? What are their stories? You know, and what are the traumas that they have inherited as a result of, you know, their experiences. And so that's why I'll always center it back to our voices need to be heard. We need to be part of the conversation when you're designing, when we're talking about novel therapies, we're talking about sometimes it needs to be patient-centered. Because the patient is a whole person. And novel therapies must be paired with mental health support, community advocacy, and robust family education to truly be effective. Um, and lastly, I just want to say I want to empower the families and allies and patients watching and remind them that they are their own best advocates. There's leverage organizations such as SCAGO, leverage allies such as Dr. Odame, um, to stay informed and to continue to demand accountable and equitable care. Community leadership and clinical excellence must walk hand in hand to change the outcomes for sickle cell disease in Ontario. And this is where the concept of Ubuntu comes in. Ubuntu is I am because we are. It's the concept of community. And the incredible work that is being done across fields reminds us that healing doesn't just happen in a clinical silo. A breakthrough therapy only succeeds if it is wrapped in a supportive ecosystem of family, advocates, and organizations like SCAGO. Let's take the medical advancements presented today and infuse them with the collective power of our community. And this is how we achieve true equity and systemic change. That's all I have to say. Thank you.
Very much for the inspiring words and almost a message of hope really for all of us to continue to support our community and to stand by one another. I would now like to open up the floor for question and answers. I guess I do have one question in the Q&A box, and while we are addressing this one, potentially other folks can leave their thoughts in the chat as well. The question I have is, how do you see gene therapy evolving over the next 5 to 10 years for people living with sickle cell disease? I think I'll turn this one to Dr. Odame.
That's a very good question. So I think to start, and I'll start with Canada first. So I think realistically, within the next 5 to 10 years, some key stakeholders, some families, some physicians, and the governing bodies that dictate how healthcare is funded in the provinces in Canada will come up with some decisions about the one that is approved, Casgevy, how we're going to fund it. negotiate with the drug company of how much it's going to cost, and ideally have some set of guidelines on who to prioritize and who gets it. So, for example, saying people who don't have a matched sibling donor, who are having very severe complications with the disease, admitted several times in a year, very significantly affected quality of life, to help guide us, because unfortunately, the reality is we can't give gene therapy to everyone. But I did talk about some other methods of gene therapy that are coming through the pipeline, particularly that in vivo method, where you don't need chemotherapy to wipe out your marrow first. You can just introduce these genes into the patient and infuse. And I think maybe closer to 10 years, but maybe 5 to 10 years, sometimes you see things progress quickly. I think we'll understand that technology a lot more. And I think it will open up some doors because, as you can imagine, if you don't need chemotherapy, the time to watch the patient and the complications will reduce drastically. And so not only will you be able to offer it in many other centers and not necessarily need a very big center, but you'll also be able to treat people quicker potentially. So, and I think even past that, we might even see more methods. There's several studies out there in very, very early trials, perhaps maybe not yet in humans, but in the lab with a few cells in a dish in the lab under a microscope. But there are a lot of different things being tried. And with the development of AI, you now have technologies that can look at data much quicker in much shorter time compared to the way we were before. So that also allows people to try different things and explore different things quicker. So I really do feel in the next 5 to 10 years, the gene therapies available will increase drastically, but also by then we'll also have some data of the long-term side effects of some of the gene therapies that were introduced now. So I think we'll be in a much different place in 5 to 10 years.
Thank you very much. Ms. Jackson, would you want to make any comments or thoughts? It's optional.
No, the
Okay.
expert has spoken.
Okay. Just in case you had any thoughts about gene therapy. I have another question. Sorry, you may have explained this before, but I had stepped out. You mentioned fertility preservation options. I think this is in maybe for either of the two. What should patients and families know about discussing fertility before pursuing transplant or gene therapy?
So I think a good transplant doctor, and the transplant doctors in Ontario are excellent and have been trained for many years. They should bring up fertility and the side effects of fertility based on the medicines you will be getting, but advocate for yourself as well. Ask the questions and know what options are available, because what's available will depend on the age of your child and the situation they're in. For sure, for children who are at puberty stage, they can offer for women egg freezing and for men sperm banking. It gets a little trickier if they're not quite at puberty stage yet, but there are still some options being explored. So, for example, some females, they are offering to save a piece of ovarian tissue, because the hope is that in the future, another thing that's also growing and developing very quickly is the ability to take stem cells from the ovarian tissue and hopefully make something out of that. So for sure, advocate for yourself. What I will say is for the non-myeloablative protocols, so that's the ones that use the lesser chemotherapy and the less radiation, the risk of permanent infertility is much, much, much lower. And even they are still offered fertility preservation before they get transplant, but even for those who don't do that, it's only a transient reduction in fertility, and a lot of them are able to make normal reproductive hormone levels several weeks after transplant. So it is something that you should ask your transplant doctor if that's something you're exploring, and ask for the specific risk of fertility based on the medicines you will be getting and what options there are to preserve if you want that as a backup plan.
Thank you very much for that insight. We had another question come in. Loved both of your presentations. Thank you. The question is for Ms. Jackson. In terms of operating from a place of grace and understanding, how can healthcare professionals and families work together to rebuild trust when past experiences with the healthcare system have been traumatic?
Thank you. That's a great question. And I would say that, you know, trauma is something that it cannot, we can't, sometimes it can't be undone, you know, and acknowledging that. But if we want to move forward, if we want to move forward, we need to understand that we are dealing with the healthcare system that was designed not with us in mind. Okay. And that is not, and I'm not going to put that on um Dr. Odame. I'm not going to put that on Dr. Simpson. I'm not going to put that on because they're not the ones that designed the system. Um, if to truly be effective and have that collaborative spirit, um, m our voices are there to inform, but we also have to give them the space to be able to do what we've come to them to do, which is to treat and care for our bodies or our loved ones' bodies. If we're not sure about something, ask. But it's science, it's medicine, and there's some things that are just not foolproof. And I, you know, for me, I never want someone who's caring for my child to feel pressured to have a solution or to, because they could, that pressure could lead them to, you know, um, and so just understanding that it takes two, it's a relationship. And we get what we put into that relationship. Um, Not always, doesn't always work that way, but what we put in that relationship, the energy that we bring into that relationship guides that relationship. And sometimes it involves having difficult conversations, you know. But also we extending if we're ex we extending grace and being gracious to ourselves too. Um, Nothing in life is perfect, you know. We're trying here, and what we're doing here, it's new, it's unprecedented, right? Um, and so I think, yeah, that's where that sort of I hope that answers. Um, yes, you've been hurt. Trust has been, but it can be rebuilt. And you know what? You can even acknowledge that to your doctor or whoever, whatever medical professional you find yourself in front of, and say, listen, this is where I'm coming from. Be honest, be open. Because when you're open and they hear that, you're humanizing yourself. You're not just a patient now. And then they get that perspective. I hope that was clear.
Thank you very much. No, you raise a lot of important points, and I think that we can all reflect and think about how we can humanize not only our perspectives, but the way we treat one another in every interaction beyond just those in the healthcare space. Okay, I have another question. I really appreciated your point about not always knowing what questions to ask. For families who are just beginning to learn about novel therapies, what are some of the first questions they should be asking? I think this for Dr. Atami.
Yeah, I can tackle that. So I think the first thing you need to ask is one, what therapies are potentially available for me or my child, right? So, for example, Casgevy, the gene therapy, is currently approved by Health Canada for age 12 and up, right? So, you need to understand what's available and not available. And for bone marrow transplant, right now in Ontario centers, it's mainly for matched sibling donors, right? So first, I think first asking the doctor what potential therapies are available to me. If we're talking about the disease modifying therapies, a lot of them are approved in US and not in Health Canada yet, right? So that I think that's the first most important question. Once you understand which therapies are potentially available to you, getting a really good understanding of what those treatments look like, how long those treatments last for, what are some of the side effects you anticipate? How is it going to change my everyday life? How long is my child or myself going to be in hospital? How often do you anticipate after they leave hospital when they'll be coming to the hospital for checkups? How, even if they're home from hospital, how long until they can go back to school? Because that's going to affect our ability to go to work, right? Or to go back to school or whatever else we're doing in our everyday lives. Like get a true sense of what it looks like rather than just the medicines alone. Okay. Then I think it's also very important to ask the doctor is the realistic timeline. So there are a lot of people who might have had discussions with their doctor or healthcare provider about transplant and or gene therapy, but there sometimes isn't always the best communication to say, hey, this isn't something we can just admit you tomorrow and start, right? Or to get a better sense of this is the wait list we're looking at right now. And then for someone to be open and transparent as of right now, we're still having discussions with the government. So we haven't actually started giving gene therapy yet. And we'll let you know when they are. And then there are some other things that determine what the best time for transplant is, right? Most centers sort of have a list of people who are interested in transplant, and they do have to sit and make the decision of who do we transplant first. And they do try to say this person is very, very sick. They've been in hospital this many times in a year. We're really worried if we don't transplant them soon, they're going to have some long-term complications that can't be reversed. So this person's going to go first. This other kid is a little bit healthier. I think if they stay on hydroxyurea, we can wait a few more months. And that's not them trying to say we don't care about your child or we care about one child or another. But in a publicly funded system, we do have to make that decision of triaging or deciding who is sicker and who needs the treatment first. So I think those are some of the main questions to ask. And it's okay to have these conversations in multiple visits. It's a lot of information, and we are human. You don't have to make the decision right there and then. It's okay to take some information, take it home with you, sit on it, think about it, discuss it with your loved ones or other people you trust to help you make these decisions. Don't forget to rely on advocacy groups like SCAGO or talk to other people in the healthcare system that you trust about it and what their thoughts are, and then go back. Because none of these therapies are therapies that are discussed quickly and decided on quickly, right? So, and if you don't understand something, ask. Because as you can imagine, and tried my best, but even me learning these things, some of these things are very complicated, right? So we don't expect people, even people who do have background in science, can be a whole new area within science. So it's okay to ask for clarification. Some people are numbers people, some people are not. So it's okay to ask for numbers if you want, but it's also okay to say, I know you keep telling me numbers, but I need you to explain this to me in a different way, right? Because some people might say, what does 80% success rate mean? Because unfortunately, I can tell you 80%, 90%, 95%. What matters is your one child or you as a person, because you won't know if you're going to be the 20% or the 80%, right? So I think getting a good sense of more than just numbers, what does each scenario potentially look like? And what are some of the things the doctors are going to do to make sure that if things aren't working, we're going to try and minimize the long-term side effects from what might happen.
Thank you very much. No, that's very comprehensive. I'm sure people might be listening back to this recording just to grab that one snippet. Maybe we'll make it into a post. Thank you very much. Um, I had a follow-up on that about how you mentioned there's only really a handful of centers that are able to do maybe bone marrow transplant at the present time. Is there any cross collaboration between hospitals and the different sickle cell centers right now to kind of like refer people to those clinics? And maybe how does that kind of work?
Yeah, absolutely. So I can speak for children. Because Toronto and Ottawa are sort of the main bone marrow transplant centers in Ontario, all the other centers do refer to those centers. So, for example, I'm currently working at McMaster. We do send referrals for some of our kids there to receive transplant at Sick Kids. They have referrals, they go to Sick Kids, or some visits are done virtually. And we have had kids at McMaster receive transplant at Sick Kids in Toronto. Um, so it is possible, even if you don't live near one of these centers, to still obtain bone marrow transplant from these bigger centers.
Okay, I think that's really reassuring because I think some families may be thinking that, oh, I don't go to one of these centers. Will I have access? So it's good to know that maybe there is an opportunity for people to still get access to that. I had a follow up, and I now have a trickle in of many questions in the in the Q&A, but I'm gonna ask my quick follow up first. Is there any evidence to suggest that potentially getting bone marrow or gene therapy at an earlier age, like maybe more in the pediatric population age versus an adult age, might have better success rates, or there might not be any evidence to suggest that?
So what I will say is for gene therapy, it's hard to say, right? Because they're new. They're currently only really approved for people age 12 and up. In general, with any chronic disease, the longer you wait, the higher risk that you're going to succumb to some of the complications of the disease itself. Some of them are reversible, some are not. But it can also create an underlying situation where you have a lot of inflammation or toxicities or damage to your organs that makes it harder to endure some of the therapies you're going to need to receive to actually get the transplant. The other key factor that sort of changes when is the best time to receive a therapy, especially for transplant, can sometimes be the donor. So let's say you are 6 years old or 8 years old, but you have a sibling genetic match, but that sibling is only a 3-month-old baby. That baby is not big enough to give up enough stem cells to you, right? So there are multiple factors that determine the optimal time to receive a treatment, and that's why it's very important to have ongoing multiple discussions over multiple visits with your physician to help them determine the best time.
Okay, no, that's really good considerations. I have a couple more. This one is sometimes I find healthcare systems and medical conversations intimidating. Any advice on how we become stronger advocates for ourselves? So it's in tandem, but maybe more on the line of advocacy. Maybe Miss Jackson, would you like to try to tackle this one about how we can advocate for ourselves a little bit?
Sure. So advocacy um is a lot of takes a lot of energy. So um I depending on where you're at in your journey, I'd say if you can even find allies, we have wellness coordinators at Skago. Um and in the different regions. Um and I would say that they're a good they're a good resource to tap into. Um because it's a lot of energy. And so yeah, definitely wellness coordinators, resources. Can you repeat the question again, or can I see it? I'm
Uh,
trying to
okay. Um, it is any advice on how we can become stronger advocates for ourselves?
strong become strong. It takes practice. Um, but and you know that saying, you gotta fake it till you, what was it, fake it till you make it or something, till you believe it. Um, you sometimes confidence it needs to be faked. You gotta pep talk yourself and say, okay. But remember, it's always centered on where am I coming from? Am I trying to make a point? What is the point I'm trying to get across? What am I trying to understand? And so whatever, like, find that one thing that's grounding you. find that one thing. What is it that you're trying to understand? What is that issue or issues that are sort of compounding? Talk it through with the wellness coordinator. Talk it through with yourself. I talk to myself all the time. People think I'm crazy, and I'm like, yes, I am. Um, but yeah. So it's also about our mental fortitude. Um, Depending on your capacity, sometimes I can't, and I go to a mentor or just and I get or for me I'm Christian, so I lean on my spirituality. I pray and I talk to my pastor or whatnot. So there's it depending on who you are and where you're at in your journey. I'd say always ground it back to what am I trying to understand or what am I trying to get across? Why is it important? Yeah.
Thank you very much. I really appreciate that. I have, I think we can do two more questions. I have one here. I believe it's for Dr. Odame. She says, sorry, I've just joined, but I have really serious question bothering me. My baby was diagnosed with sickle cell disease, and they're now 7 months old, and she has half siblings. Can they be a match for a stem cell transplant? Because honestly, I don't want to risk getting pregnant again because the doctor told me there were chances are high that I can get another baby with sickle cell. Yet I want to help my baby.
That's a very good question. And so just to clarify, by half siblings, that means they only share one parent? Is that, I just want to clarify from whoever asked that question. So,
I don't have a response on my end.
so if by half sibling, what I think they meant is they share one parent and not both parents, um, then the chances there'll be a full match are a lot lower. Usually to be a full match, has to be people who share both of the same mother and the same father. What I will say though is your baby is 7 months old. Within your baby's lifetime, there probably will be some improvement in the methods we use for half match transplant. So potentially you or a parent could be a match or a donor for the transplant, and the other curative therapies will probably develop as well. Um, because your baby's 7 months old, there is some time to see what happens because we don't typically offer transplant for people this young. Um, and in the meantime, I would really encourage you to speak with your provider about other medicines you can take by mouth. I think hydroxyurea would be a really great thing to consider for your baby because that's how we can reduce complications from sickle cell while we're waiting on hopefully a curative therapy when they are older.
Thank you very much for that. I will now ask, I guess, a final question for any last remarks from either of our panelists about novel therapies, about messages to families, about considerations for how to interact in healthcare spaces. Just open the floor if there's anything left to be said. I'll turn it to Dr. Odame first and then Ms. Jackton.
Um, so what I'll say is the information is a lot. It's a lot for healthcare providers because the landscape is changing so often. And so I imagine it's even a lot for the patients and the families. Continue to ask questions. Know that the information can change, but advocate for yourself. Uh, I don't have the experience of living with sickle cell disease, but I am also a Black female who has to navigate the same healthcare system. So I have a little bit of a sense of what it's like to be in a healthcare system that doesn't seem like it was made for you. It can be really hard to build trust. It can be really hard to know when it's safe to speak or safe to speak up. but this is where I think advocacy groups like SCAGO can be really helpful. The group has people from all different areas of expertise, healthcare, advocacy, public health, wellness, um, government bodies. So if you need some help, reach out. There's always someone they can ask or someone that can support you through this. You're not alone because ultimately, that's great that a lot of scientists and a lot of really smart people have developed these things, but what's the point if they're not actually going to help our community, right? So we will do our best to continue to inform you and support you, but we also encourage you to reach out if you need help.
Thank you very much. And Ms. Jackson?
Thank you, Dr. Odame. Um, I just had one last question, and it was regarding the bone marrow transplant. Um, I so when there's a successful bone marrow transplant, is that patient still SS? Like, let's assume that it's SS, that their genotype is SS. Do they still remain SS or does it change?
What happens is if the transplant is successful, you should start to make more hemoglobin F. And when you make more hemoglobin F, ideally, and I'll talk about the non-myeloablative protocols, right? But ideally, you want to get upwards towards 30%, 40% hemoglobin F. So high enough that it doesn't really matter as much the sickle cells you're making because you're making enough of those hemoglobin F healthy red blood cells that it essentially cures you of the disease. It's kind of like how if someone's AS, they do still make some S, but because they make enough A, the amount of S they have doesn't matter. And that's what you're trying to achieve when someone has transplant. In a non-myeloablative transplant, there might still be some S, but the amount of F you're making is high enough to protect you. And essentially you end up being like someone who doesn't have sickle cell disease, because in sickle cell disease, you are SS, so you're making hemoglobin S.
Okay. So basically that person with SS should, even though they've undergone a successful bone marrow transplant and they have a partner, let's say, who is AS, still maybe avoid, not avoid, I don't know what word to use,
And
but
sorry, I just realized, don't mean to interrupt you. I misspoke. When I said I was talking about transplant, I was talking about gene therapy. That's
gene
where you
therapy.
make more hemoglobin F. I apologize.
Yeah, no.
For transplant, you're going to make more hemoglobin A because that's what the donor was. The donor was either AS or AA. So you'd be making more hemoglobin A rather than hemoglobin F. I apologize. I was thinking of gene therapy. But sorry, what's your next question?
No, it was just on, so if someone has undergone a successful bone marrow transplant, they still remain SS, but and let's say they're dating. The, should they still avoid, like, does it still matter the other person's, like their partner's genotype?
This is, sorry, am I unmuted now? This is a very important question, and I'm glad you brought this up. So transplant will change the DNA in your blood, but it doesn't change the DNA of your reproductive cells, right? So it's still absolutely important to test your partners and get tested. For those who do fertility preservation, um, uh, you can have a better sense of testing embryos beforehand. But if you're hemoglobin SS, you have to know that you still need to test your partners.
Thank you. Thank you.
And Ms. Jackson, any last words? I know you're full of curiosity, but any last words?
No, I just wanted to thank Dr. Odame for being here with us, for yeah, your time, your expertise, your heart's work. Um, And oh, I think someone here is it
I-
possible to give a brief about the status of gene therapy in Canada? In Canada, their success
Mm.
stories. I don't know if you wanted to
So I
address.
can touch on that really quickly. So essentially where we are with gene therapy for sickle cell in Canada is what happened is in September 2024, Health Canada approved Casgevy, which is the gene therapy for use in Canada. But that's just the first step. So first there's approval, but right now what we still need to figure out is the price in US right now is 2 million US dollars, the price for the drug for one patient. What's happening at the government level right now is there's still ongoing discussions with healthcare providers and the drug company about how much it's going to cost and how the government's going to fund it. And then once we decide how to fund it, how we're going to decide what criteria someone needs to meet to be prioritized to receive gene therapy. So there's still a while before we actually start giving it regularly to people age 12 and above. But what I would say is within the next year or so, I anticipate we'll get some of these answers and then actually start to do that. You might have heard of some people on some potential trials where there's some other gene therapies here and there. But for the most part, for the general population, that's where we're at. And sorry, I see another question. Is it possible to not be recommended for any sickle cell treatment? And if yes, why? So I would say yes. So right now, let's say if you were in a clinic in Ontario, transplant might not be offered to you because you don't have a genetic match, full sibling. Okay. Sometimes you might have some toxicities or some damage to your organs that make a certain type of treatment risky. I think the chance of this is a little bit less because non-myeloablative isn't as toxic, but it can happen. If you're sometimes you can be too sick to get transplant. And as of right now, the gene therapy isn't being regularly offered yet, right? So those are some of the reasons why you might not be offered. It's also important that the doctors are also transparent with you. So let's say you have a child who's unfortunately very devastated by the complications of sickle cell disease. There's only so much a transplant can reverse, right? If you have unfortunate, as you know, some people with sickle cell can get strokes, and if they get very serious strokes, they can have brain damage that no transplant can reverse. So sometimes a doctor might be open and honest with you and say we can offer the transplant, but if unfortunately your child has been devastated by the effects of stroke, it's not going to change. They're not, if they have difficulty walking, they might not walk again. If they have brain damage, it might not come back. It can't fix some of the damage that's already happened. So those are some of the reasons potentially why those curative therapies would not be an option for you or your child.
There was a comment.
The response I got from a consult was not having an extreme sickle cell disease condition. So what I will say about that is I don't know if you're here if I talked about it earlier. So for the curative therapies we have, they sit down and there's a wait list of people who might be interested and they go down the list and they usually offer it to people who are devastated by the disease first. Um, so it could potentially mean, and I don't want to speak to the consultant without knowing your full medical history, but I think realistically, if someone is very if their sickle cell disease is very well controlled, the doctor might be honest with you and say there are people who are sicker than you who will probably get it in the next couple of years before you do. But that's the comment I can make without knowing the full details of your medical history. And there are different types of sickle cell as well, right? So there's SS, there's SC, there's S beta thal. So different ones have different severities. So that might play into the reasoning as well.
Thank you very much to our two incredible panelists. We have learned so much from both of you. This is an incredible and unique opportunity to share insights and learn from the community to the community. Thank you very much for your questions, for your curiosity, right? This is really you showing up and making sure that you have access to lots of different information making sure that you're well equipped to make decisions for yourselves and also to advocate for yourselves in spaces when you're have the opportunity to engage with this material. I encourage everyone to continue coming to our Learning for Life sessions. As we can see there's lots of high quality information when we come to these. I've learned a lot myself. And I would like to just close off this session again with a lot of gratitude and appreciation and want to just wish everyone a wonderful weekend as well. Thank you very much.
Thank you. Thank you, everyone.
Thank you.
Thank you.
Thank you, everyone.
Enjoy the rest.